get it done quick. Okay, good morning. Here's the topic we're going to talk about. Not really relevant to GI because this is the more like soft tissue part. So we have 4 entities. The first one is sclerosing mesenteritis, aka mesenteric pendiculitis. So here's the scope picture. So this is an idiopathic non-neoplastic condition leading to this thickened and shorten of the small bowel mesentery. So kind of fibrosis, something just kind of scar to just get everything just stick together. And then the patient usually is a middle-aged or older man. So the histology finding, I think we just need to remember 3 things. We have this fibrotic tissue, and then we have this, even this low power, we can see this unhealthy fat. Why I say that compared to this maybe relatively more normal adipocytes, these adipocytes are back-to-back together, and then between the adipocyte, there is no thickening stroma. But this nodular fat necrosis, we can see these hyaline sclerosing material between individual adipocytes. And then we can also see the size of the adipocytes are different. Some adipocytes are bigger, some are smaller. So this is the nodular fat necrosis. And then surrounding the necrosis, we have this spindle cell fibroblast proliferation, kind of rimming this nodular fat necrosis. And then other than that, we can see lymphoid aggregation around. So if we see these 3 features in the mesentery, we can have this diagnosis. Then more picture, we can see this lymphoid aggregation, and then fat necrosis, this spindle proliferation of the fibroblasts. And then here's the high power view to show this fat necrosis. And then around this adipocytes, we can see some histiocyte. And then another entity called Weber-Christian disease, aka relapsing febrile nodular pendiculitis. And then I think the histology finding is identical to the sclerosing mesenteritis. Only difference is this is female predominant, 30 to 60 years age. And then they have other finding other than the mesentery. There is recurrent tendon erythematous subcutaneous nodule of leg and trunk. And then patient also had malaise and fever. And this finding can also seen in pericardium, bone marrow. So then go to the next entity, IMT, inflammatory myofibroblastic tumor. This entity terminology is about myofibroblastic spindle cell neoplasm of predominantly children and young adults. So usually in younger patients, and then around half of them with ALK gene rearrangement. So we can use the ALK ISC to confirm the diagnosis. And the most common sites will be abdominal, pelvic region, because when you see the histology, kind of like overlap with nodular fasciitis. So this common anatomy site is really helpful to help us to favor which diagnosis when we have this entity. And this is the tumor. We do not know its clinical significance because 35% may recur and less than 5% may metastasis. And then the growth finding, this is a cutting surface, just like sarcoma-like which meet really fibrotic surface. And then I think this IMT should be bigger than the nodular fasciitis. This is another clinical point. So for the histology finding, we usually see these spindle stellate cells have this on this loose myxoid stroma. And then these cells are usually forming this like vesicle or even vaguely storiform. We somewhere when we may see some hypocellular and sclerotic matrix. So the characteristics cytology feature is we can see this cell spindly looking, and then with open chromatin. Usually the nuclear line is not that prominent, but we can still see this pentane nucleoli. And then the cytoplasm is kind of amphiphilic light purplish. Here we show this more cellular area with a myxoid bluish background. Then there's some of these spindle cells forming this vesicle growth. We also can see extravasated red blood cells, so there's really kind of overlapping with the nodular fasciitis. And then tons of different kinds of inflammatory cells, including lymphocyte, eosinophil, neutrophil, and even plasma cell. This is a high power view. We can see tons of plasma cell in the background. Some of IMT can also form this herringbone fracture, just to make us confused whether this is an MPN-ST or any other sarcoma. And then sometimes we can also see this hyaline stroma. These two pictures also show the sclerosis stroma. One thing sometimes why we call this sclerosis, not fibrosis, because in sclerosis we have this thickened collagen bundle, but without tons of nucleus. If fibrosis, we will not only have this collagen bundle, we also have more cells nucleus. So when we do not see a lot of nucleus, just a collagen bundle, we call this sclerosis. And then here's the anti-staining show vague storiform growth pattern of this spindle cell. Here's a high power to show the cytology feature of IMT. These are plumb spindle cells with this open chromatin, and then some with this punted nucleoli. Another high power view, open chromatin, light purplish amphiphilic cytoplasm. And in some area of IMT, you may also see this prominent nucleoli just resembling Stumber cell or virus infection. And some area you may also see this hyperchromatic smudgy chromatin of this myofibroblastic cells. So the immunostaining is positive for SMA, but SMA is really not any specific. So SMA can be positive in a lot of spindle cell, including the small muscle, skeletal muscle origin tumor. So it's not specific. I think for these entities, more specific is ALK, but only positive in 50 to 60% of the cases. If the ALK negative, we can also try to do ROS1, because ROS1 will may be positive in subset of ALK negative tumor. And some tumor also have this ETV6 and TRK3 fusion. And then for other melanocytic or neural marker, S100 SOX10 will be negative and myogenic negative. So for the differential diagnosis, the first one, we need to bear in mind that it's nodular fasciitis, but the anatomic sites will be commonly in extremity and usually small, less than 3 centimeter. And histology finding to tell them apart, one is 60 changes. I have digital slide show you later. Just bear in mind 60 changes even in low power. And then high power, we can see this tissue culture-like fibroblast. But I think this tissue culture-like fibroblast kind of overlapping with IMT, so not really reliable. And of course, ALK negative. And then the good thing for nodular fasciitis is that we have this MYH9 USP6 translocation, so we can send out fish for this USP6. Another considering differential should be leiomyosarcoma, but I think it is not that difficult to tell them apart. Especially in leiomyosarcoma, we usually can see muscle differentiation and more mitotic figure, more polymorphic of the cells. And then also leiomyosarcoma should be in older patient. And of course, L negative in leiomyosarcoma. Then another differential is pseudosarcomatous myofibroblastic proliferation. So for this one, also clinical pathology had overlap with IMT. So this is also a controversial entity. People didn't know whether these two are the same or different, but the anatomy site usually in the genitourinary tract, typically in the bladder. And then in this diagnosis, also find ALK positive with ALK rearrangement, but ROS negative by all reported cases. And then the molecular finding is FN1 ALK fusion. So let's see. Okay, so let's see some digital slide. This is for the first entity we just talked about, that is sclerosing mesenteritis. So low power, we know just like a piece of connective tissue, including adipocytes. Even in this power, we can see some lymphoid aggregation. And then some fat is healthy, but in the middle, we can see these facts. We know that that is fat necrosis because the adipocyte size are different. And then between the adipocyte, we have this hyaline fibrotic stroma. So this is fat necrosis. And then around the fat necrosis, we can see some spindle cell proliferation in the periphery, and then combine this lymphoid aggregate. So we can make the diagnosis of sclerosing mesenteritis in this piece. So let's go to our next entity, IMT, inflammatory myofibroblastic tumor. So several pieces of light soft tissue. And then we have some area with the more myxoid stroma and more hypercellular area. Let's take a look at what's inside in the high power. We can see some inflammatory cells, sparse, not tons of it in this view, but we can see this characteristic plum spindle cell, myofibroblastic cells, myofibroblasts. And then this cell is blunt, spindle looking with open chromatin, not prominent nucleoli. Of course, we have some cells with hyperchromatic, and they're all extravasate red blood cell. Let's go to another view to see whether we have more inflammatory cell. Here in this view, we can see even neutrophil here. And then also again, this open chromatin with light purple-ish cytoplasm spindle cell. So when we see this feature, we will think about IMT. Let's see another case. Low power looks quite similar. We have some hypocellular area and hypercellular area. And usually in the hypocellular area, we will see more inflammatory cell. And then the hypocellular area, we will see myxoid edematous stroma. And then this case also forming this fascicular growth, swimming fascicular, and also vaguely storiform. And then the cytology feature are characteristic for myofibroblasts. We have this open chromatin, not prominent nucleoli, light purplish cytoplasm. And then go to the more hypercellular area, we will see a lot of inflammatory cell. This is lymphocyte, maybe some neutrophil here. And then I think from Dr. Gardner, he always mentioned a true IMT. That means if you take out all of the reactive blood vessel, red blood cell, and inflammatory cell, what you left is this spindly characteristic fibroblast. That is true IMT, because in pseudo-inflammatory proliferation, when you take out all of this granular tissue, not tons of this myofibroblasts left, so that is not a IMT. Another common location for IMT is in the lung. We can see this is relatively normal lung tissue, and then we have this nodule or spindle cell proliferation. We also can see this fascicular growth pattern, but this one, I think the HA staining may be so dark, so we could not see really characteristic of the nuclear feature. Here, we just can see this hyperchromatic spindle cell proliferation, and then with a lot of inflammatory cells. Let's see one more. So in this example, I think that, yeah, this one, the staining is not that dark, so we can see our myofibroblast, spindle cell, open chromatin, not prominent nucleoli, spindle cell forming this vesicle, and then in the background of this edematous stroma with different kind of inflammatory cells, even like plasma cell. So for one of the differential, as I mentioned, that is nodular fasciitis. So even in low power, kind of different, because maybe in this area, they are really identical, but in this area, this is the cystic changes. So when you low power see a soft tissue mass, you see these cystic changes, you should bear in mind whether it is nodular fasciitis, even in this really scanning low power. So we can zoom in to see what cell inside. Also spindle cell proliferation with some inflammatory cells and extravasated red blood cell. And then this kind of looking is called a tissue culture-like fibroblast, because the cell, not just spindle looking, they have this stele, just like you put a cell and then drop the cell onto the floor, and then the cell just have this stele looking. This is called the tissue culture-like fibroblast. But for me, it seems like kind of overlapping with the IMT. So the anatomic location and the size of the lesion, and of course, we can order USP6 for FISH to confirm the diagnosis. Okay, let's continue. We're almost done. We have the last entity to talk about. There's the desmoid fibromatosis. So this is a clonal fibroblastic and myofibroblastic proliferation arising in deep soft tissue, and also usually just local recurrence and do not metastasis. But for the text purpose, it's associated with familial adenomatous polyposis and Gardner syndrome. And most common in the GI tract is the small bowel mesentery. So in the CT scan, we can see this soft tissue mass, and then the cutting surface also really fibrotic cutting surface. And then the histology finding, even in low power, we can see this long vesicular growth of spindle cell just dissected into the muscular propria. And then compared to IMT, there are not tons of inflammatory cells, just this spindle cell proliferation and monotonous cell proliferation. So we also can see this long vesicle growth of these spindle cells, and how we tell the difference between spindle cell, muscle, and also neural, because in these fibroblasts or myofibroblasts, between these two spindle cells, we can see this collagen fiber. In the high power, you will see more clearly. So that is fibroblast or myofibroblast proliferation, not muscle, not neural. And then can also forming this storiform pattern, and sometimes you will see this perivascular clearing, called its edema. And also dilated vessel, and also myxoedematous stroma changes. And also kind of infiltrated border going into the fat, and also wrapping muscle cells. And then for the immunostaining, because this myofibroblast, so also SMA positive, but rarely desmin positive, because desmin positive should be true muscle differentiation, not just myofibroblast. And then for the other differential, CD34 negative, H-desmin negative, STAT6 negative, because STAT6 is for SFT. And then more specific immunostaining, there is the nuclear beta-catenin positive in around 75% of cases. And then for the molecular finding, that is the CTNNB1 gene for the protein beta-catenin, that is sporadic tumor. If in FAP or Gardner syndrome, we will see mutation in APC in chromosome 5q. So here just show the beta-catenin nuclear staining. So just remember, whenever you want to say beta-catenin staining, you need to see whether it's a nuclear cytoplasmic. Oh, let's see the last few cases of this fibromatosis. So the first one is in the small intestine. If in low power, we know this is the normal muscular propria, and then we can see some spindle cell infiltrated into the fat and also into the muscle. For this one, and then we can clearly compare the smooth muscle and this fibroblast. Between the fibroblast, we have this collagen bundle between. So just this spindle fibroblast, myofibroblast proliferation in this location, infiltrated border, and then we can do the beta-catenin to confirm our diagnosis. And then this is another desmoid fibromatosis from the abdominal wall. This is the fascia. This is the skeleton muscle. We see this spindle cell proliferation tumor just wrapping the skeletal muscle and then forming this characteristic long vesicular growth. And then we want to see the cytology feature, also open chromatin with not prominent nucleoli, and then this spindle light purplish and amphiphilic cytoplasm. And then between this spindle cell, we have this wavy collagen bundle. So we know this fibroblast or myofibroblast. And we have some of these cells just mimicking nuclear giant cell, but these cells are not histiocyte. So that is not multinuclear giant cell. These cells are the atrophic skeleton muscle cell. So when the fibromatosis wrap the skeleton muscle, it will cause the skeleton muscle atrophy. So this is the nucleus from the skeleton muscle cell. So just like wrapping and then they shrink together to mimicking multinuclear joint cell, but actually they are not. So let's see the last slide. Also really similar finding of this long vesicular growth fibroblast with this collagen bundle between an open chromatin lipoprotein cytoplasm. And then infiltrated growth dissected into the fat. And then we have some lymphoid aggregation as well. So this is another desmoid fibromatosis. So I think